काय प्रॉब्लेम तर मी काय
म्हणजे बंद करायचं त्याला
कॉम्पोनंट
गोष्टी चालून फॅन टीव्ही सगळं चालू
क्लास चालू आहे माझा. Hello friends, we will start within a minute. Okay friends, good afternoon. So last lecture we have discussed till the complete we have completed the examination of the eye. So most common case that will be given to is of cataract. So let us discuss something about cataract. So basically what is lens? This lens is like a lens, it's like a lens of the camera which can increase or decrease its power, like the camera lens. So basically as the age progresses, the lens becomes grayish white in color because of the physiological changes in the lens fiber, and once these changes are exaggerated, then it can cause the lens will become opaque and it will lead to cataract. So that is what is cataract. Basically cataract is nothing but opacity of either the lens or its capsule. So if you see, the lens has got various parts, like this is posterior capsule, this is anterior capsule, then cortex, and in the center there is nucleus, and there are various layers of nuclei according to the age. Let us not go into the details of the nuclei. So any part of the lens can become opaque, like the anterior capsule or the posterior capsule or the area beneath the posterior capsule or cortex or nucleus, and depending upon that there are various types of cataract. So opacity in any part of the lens or its capsule is called as cataract. And the most common cause of cataract is of course age, so that is called as senile cataract, or it is age related cataract. So this picture shows in the right eye, if you see, the both pupils are dilated, and the right eye pupil, you can see a proper white cataract, it's a mature cataract, while in the left eye it appears that lens is implanted, artificial lens is implanted into the eye, so that's why it is the pupil is exam black in color. Otherwise at this age you'll expect some grayishness of the pupil, so it is mostly pseudophakia. So this is the morphological classification of cataract. As I was telling you, that this cortex may be affected predominantly, leading to cortical cataract, or nucleus of the lens may become opaque, leading to nuclear cataract. And these are two poles of the lens. This is anterior pole and posterior pole. So sometimes only the pole becomes opaque, leading to and either anterior polar cataract or posterior polar cataract. And a very common type of cataract is called as posterior subcapsular cataract, in which the opacity is formed just anterior to the posterior capsule. So that's why it is called as posterior subcapsular cataract. It is very logical that this posterior subcapsular cataract is smack in the visual axis. So even if very early posterior subcapsular cataract will cause profound diminution of vision. The rest of the lens is transparent but not opaque, but a small opacity here will lead to profound disturbance of vision. On the contrary, if whole of the periphery is opacified, still there will be no difference in the visual acuity because it doesn't come into the visual axis. Yes. So this is how the various types of cataracts look like, friends. So this is normal lens, which I already told you that it is black. So the pupil appears black in color and it is transparent. And in immature lens, it is grayish white. And when it becomes mature, it becomes to white in color. Or it is called as pearly white. And the hypermature cataract, the lens is like yellowish in color. And in nuclear cataract, depending upon the hardness of the nucleus, it could be either white, it could be either yellow or black or blue in color. So a very common question that will be asked to you in the exam is, how will you differentiate between mature and immature cataract? So this is a very common question that will be asked to you in the exam, because either you will get a mature cataract or immature cataract. So how will you differentiate between these two? So basically the differentiations will start right from the history. In the history itself, we can ask the patient how much is the visual impairment. If the patient is able to read the letters or still able to manage his day-to-day activities, then probably the cataract is immature. Whereas in mature cataract, the patient will not be able to see anything from that eye. So that is the first difference. Then on the examination, the first point in the examination is visual acuity. So in visual acuity, in immature cataract, the visual acuity will be reduced, but it will not be profoundly reduced. It will be usually more than 6 by 60. It will be in the range from 6 by 60 to 6 by 9. But in case of mature cataract, the vision will be like finger counting or hand movements or perception of light. So the second point is the visual acuity is profoundly reduced in mature cataract, whereas the visual acuity is reduced, but it is not profoundly reduced in immature cataract. Then the third point, which I already told you, the color of lens. The color of lens is white in color, pearly white or milky white in mature cataract. Whereas the color of lens will be like grayish white or amber or black or yellowish in case of immature cataract. So this is the third difference. And the fourth difference that we can see with the distant direct ophthalmoscopy. When you see the patient with the distant direct ophthalmoscopy, you will see a red glow in normal patients. And in immature cataracts, you will see a black opacity against the red glow. But you will see a red glow. It may be faint, but you can see the red glow. Whereas in mature cataract, you will not see red glow. And the last difference is iris shadow. Iris shadow will be present in immature cataract, whereas it will be absent in mature cataract. So in a nutshell, you please remember these differences, like visual acuity, color of the lens, and iris shadow. So these are the differences between mature and immature cataract. Yes. So again, for the sake of repetition, the iris shadow in immature cataract is still visible. The opacification of the lens is irregular. Some areas are opaque and some areas are not opaque. So you can make it out by dilating the pupil and examining the patient with slit lamp. And it will progress gradually. Whereas, yes, when there is a clear cortex between iris and the opacity, the shadow of iris which falls upon the opacity will be seen through the clear cortex, and this is called as iris shadow. This is a very common sign in immature senile cataract. Basically, we can see the shadow of pupillary margin, the iris at the pupillary margin, which will be cast on the lens. Yeah. So this is because of the due to the presence of clear interval between iris and lens opacity. So in case of mature cataract, there will be usually severe decrease in vision. There will be complete opacification of the lens capsule and cortex and nucleus, and the lens will appear pearly white in color. So this is the picture of mature cataract. Again the same thing. Visual acuity is reduced in counting fingers. Visual acuity is reduced to hand movement or perception of light in mature cataract. The lens is partially opaque. The lens is totally opaque. Iris shadow is present. No iris shadow is present in mature cataract. And fundus means fundal glow will be visible, whereas you will see no fundal glow in mature cataract. So once the cataract becomes mature, then it can, if we don't operate, it can become hypermature. What happens that the lens cortex, the cortical fibers will liquefy, and the because of the liquefaction of the cortical fibers, the lens nucleus will sunk inferiorly into the capsule, leading to Morgagnian cataract. And in case of this Morgagnian cataract, small defects will appear in the anterior capsule, and through these defects, the lens protein can go into the trabecular meshwork, leading to glaucoma. So this is called as phacolytic glaucoma. Phaco means lens, lytic means lysis. So this glaucoma is because of lysis of lens fibers, and this glaucoma is called as phacolytic glaucoma. Sometimes what happens that the lens becomes swollen, and it will occupy a large space in the eye. It will push the iris anteriorly, and it will cause closure of the angle of anterior chamber, and this also leads to glaucoma. So this is called as phacomorphic glaucoma. So there are two types of glaucoma which can be seen in hypermature cataract. One is phacomorphic and other is phacolytic. And the treatment of this both type of glaucoma is, the definitive treatment is, it is caused by the lens. So we have to remove the lens. So we have to do cataract surgery. So this, if you don't operate hypermature cataract for long time, then if glaucoma remains for long time, then it will damage the optic nerve, and there will be optic atrophy, and patient will not gain vision even after cataract surgery. So basically, what is happening is the blindness in cataract is a reversible, treatable blindness. But if you don't operate, then it becomes irreversible and non-treatable blindness. So this is a picture of hypermature cataract. So this is beyond the scope of this practical class. So what happens in diabetes? Basically, in uncontrolled diabetes, there may be formation of cataract, and that cataract is called as snowflake cataract. Okay. So these are some of the symptoms of cataract. So in the initial phases, patient may not complain of diminution of vision, but what the patient complains is glare. Patient will complain of glare. Matlab, he will see the light, which especially while driving, the light in the front will appear dazzling to the patient. It will blind his eye. मतलब गाड़ी चलाते वक्त सामने की लाइट से the patient becomes blind, because patient cannot see. So this is called as glare, and that is the initial symptom of cataract. And there will be diplopia. So this diplopia is uniocular, means what happens, suppose there is cataract in the right eye, then from the right eye the patient will see two images even if he closes the left eye. In contrast, in paralytic squint, the diplopia is binocular. If the patient closes one eye, the diplopia will disappear. But in case of cataract, it will be monocular diplopia. So this diplopia is not seen in all objects, friends. Only in case of when the patient looks at some bright objects such as light source or a moon, he will say multiple moons. So that is polyopia, or two moons. So this is monocular diplopia or polyopia. That is also a common symptom of early symptom of early cataract. So there will be glare and monocular diplopia. Then the patient will then complain of progressive diminution of vision for distance, and finally patient will say कि मुझे सामने का कुछ नहीं दिखता है, चेहरा नहीं दिखता है. He is not able to identify the faces of people or what is happening on the road. So that is the symptom. In many patients with nuclear cataract, surprisingly, the near vision will improve. So this is because the cataract will induce some degree of myopia. So that is called as lenticular myopia. So patient will say कि मुझे पहले नज़दीक के लिए चश्मा था, लेकिन अभी चश्मा नहीं लग रहा है मुझे नज़दीक के लिए. Patient is able to see the near objects clearly. So that is, patient will say that, patient will feel that that's a good sign. He has got a second sight, but this is early manifestation of nuclear cataract. Slowly, his distance vision will reduce, and his near vision will also reduce. Yes. So this is how patient normal vision looks like. Through the early cataract, patient will see like this, and when as the cataract becomes advanced, patient's vision will reduce proportionately. So this is example of glare. So when the patient is driving, Normally he will see bright light of the opposite vehicles, but his eye, the image will not, his vision will not dazzle. So here you can see that his vision is dazzling. Okay, so this lastly, so I hope you have understood what I am trying to tell you. I am trying to tell you only practical points of cataract. I am not telling you any theoretical points. So management, so the definitive management of cataract surgery is operation, but when to operate always doesn't depend upon the surgeons, it depends upon patients. So what is the answer for this? The answer is when the patient feels that his day-to-day activities are obstructed or affected by presence of cataract, then he should undergo cataract surgery, and this may vary from patient to patient. For example, a pilot or a doctor will feel a difficulty with 6 by 6 vision also in presence of cataract, whereas a farmer may not feel difficulty in day-to-day activities with 6 by 60 vision also. So this depends upon patient. So this is called as visual indication. So the first type of indication in cataract is visual indication. So this is a visual indication. Then the second indication is medical indication. Medical indication means even if the patient sees normally, patient doesn't complain of diminution of vision, we operate. So why do you operate? Because it is medically indicated. For example, if the patient's intraocular pressure has risen because of cataract, we operate. Then sometimes the patient has diabetic retinopathy or any retinal disease, and we are not able to treat this retinal disease because of the presence of cataract, because this laser may not penetrate the, may not be, will not, may not be able, we may not be able to do the laser treatment of diabetic retinopathy because of presence of cataract. So we remove the cataract. So this is called as medical indication. So the first indication is visual indication. The second indication is medical indication. Then the third indication, friends, is cosmetic indication. Means patient has got optic atrophy in that eye. Patient will not be able to see anything even after removal of cataract. But the patient doesn't want that white opacity in his eyes. So we remove the cataract. So that is called as cosmetic indication. So basically, in the initial stages of cataract, we can try to change the glasses and prolong the surgery, but the definitive treatment is surgery only. And we can also advise the patient to use better lighting for seeing. So these are the types of surgeries that we have to remove. Yes. So this ICC in all is obsolete. So now we'll stop about surgery here. So what we will instead will do is we have now taken a decision to operate the patient. So how do we proceed? So basically we have to do some local investigations and then we have to do systemic investigation. So locally first we have to do complete eye checkup. Whatever I told you from the beginning, we have to do a complete eye checkup. We have to check the retina also with dilated after dilatation with the help of direct and indirect ophthalmoscope. We have to check the intraocular pressure. Then we have to do the regurgitation test and we have to see for other focus of infection also before taking the patient for cataract. So these are the tests that we do. These are the local tests that we do before taking the patient for cataract surgery. So we do a complete eye examination. Then after doing a complete eye examination, then we do some systemic tests, like we do check the blood sugar, because if the blood sugar is high, then the patient we don't operate the patient, because diabetes will affect the wound healing and it can also predispose for infection. So we control the diabetes. Then we do CBC again for just to rule out CBC and urine examination, just to rule out any focus of infection. So because if there is an infection, the infection can go into the eye, so we don't want to operate. So we do blood sugar, we do CBC, we do urine. Then whatever tests which are required for anesthetic fitness like ECG, chest X-ray, we do. We check the blood pressure of the patient also, because uncontrolled blood pressure, there is a risk of bleeding in the eye during surgery, and there is a risk of anesthetic complications. So we control the blood pressure. So these are some of the tests, systemic tests we do. Then after doing these tests, then basically what we have to do is something called as biometry, because normally now we insert an intraocular lens into the patient's eye. So we want to know how much is the power of the, what power we should implant. For that we do a procedure called as biometry. So in that biometry there are two things. One is corneal curvature. So this corneal curvature is measured by an instrument called as keratometer, and then second is axial length of the eye, that is measured by ultrasound A scan. So we do this keratometry and ultrasound A scan to check the axial length, and then we fit the readings into a formula called as SRK formula to find out the power of intraocular lens that has to be implanted. So normally the normal power of the intraocular lens will be around 20 to 21 diopter. But if the patient is myopic, then he will require less powered lens, whereas the hypermetropic patient will require more powered lens, because our aim after surgery is that patient should be immetropic, मतलब patient को चश्मा नहीं लगना चाहिए. But patient will definitely will 100%, we cannot guarantee immetropia in 100% patients, because there are other factors also. Our biometry may not be accurate. Then we we take an incision, and this incision will also cause some amount of refractive error, that is called as astigmatism. So because of that the patient will not be 100% immetropic, but at least the spherical power will not be there, so we do biometry for that. So these are the local tests that we do. So today what we have covered is, we have covered the differences between mature and immature cataract. Then we have covered the indication of cataract. Please go through these indications very minutely. There are only three types of indications. And then we have covered the preoperative workup of patient of cataract. So in the next class, what we will do is we'll try to learn about the steps of cataract surgery, and we'll try to learn about the complications of cataract surgery. I think there is a YouTube video in my channel wherein I have discussed about the management of cataract. Please go through this video, and we'll do that. And subsequently we'll discuss pterygium, because pterygium also will be given to you as a long case, and then we'll try to teach you about instruments and optics. So do you have any doubt till now today? Please respond. Yes, do you have any doubt?
No, sir.
Okay, okay. So now what we can do is, for the next class, one person can take a complete case now, because now I have discussed history, I have discussed examination. So take a complete case. You may not be 100% correct. There is no problem. Just take a case of, let us assume that one patient has got mature cataract in the right eye. So build a case on that completely, right from the history to the examination. So we'll discuss that, and all of you will be present, so that you will know what to write and what not to write in that case. So I will correct the case. So one person can take the case, and he can send me the case before the class. I will go through that and we'll discuss that. Okay, if a person wants to present himself, he can schedule a Zoom class himself or herself and present. I don't mind that. And then we'll do that, and then we'll discuss about the complications of cataract surgery. Okay. So when are you going to take case? Because next week I may not be having time to take your classes in the daytime, because of clinical work. I have to attend the OPDs. So I might take your classes in the evening next week. But tomorrow I have time. So if you can take case tomorrow, we'll discuss. Okay. Is there any doubt? Is there any doubt?
No, sir.
Okay, so we'll stop it here today, and please take a case. Then we'll discuss about subsequently about cataract and pterygium in this week only, and next week we can take about your instruments and optics. So that will complete the, I mean, whole the what things needs to be covered in the during the clinical posting. Okay. Okay then. Bye, friends.